Do you really need a pancreas? Hi, it's Dr. Fan here. Let's talk about chronic pancreatitis. Chronic pancreatitis results in the irreversible damage to the pancreas due to a chronic inflammatory response. It has an incidence of about 5 to 10 per 100,000 and is associated with recurrent pancreatitis, alcohol, smoking, hypertriglyceridemia, pancreatic duct obstruction, familial pancreatitis, and autoimmune pancreatitis. The underlying pathology involves the progression of inflammation and loss of acinar and islet cells, which leads to further activation of the pancreatic stellate cells to cause fibrosis, loss of cellular architecture, and deposition of calcifications. Those affected may be asymptomatic because pancreas functions are sufficient even with only 10% of the pancreas. However, the most common presentation is chronic abdominal pain, which is worse with eating. Pancreatic insufficiency can be endocrine or exocrine. Endocrine insufficiency results in diabetes mellitus and poor blood sugar control, whilst exocrine insufficiency results in malabsorption, particularly fats, which causes steatorrhea and deficiency in the fat-soluble vitamins A, D, E, and K. The workup for chronic pancreatitis involves blood tests and imaging, much like for acute pancreatitis. For more information on acute pancreatitis, check out my video below. However, there are differences between chronic and acute pancreatitis. Lipase is likely to be normal, but IgG4 and triglycerides may be abnormal. We would also test for fecal elastase, which is low in pancreatic exocrine insufficiency. CT or MRI can be performed to assess for pancreatic atrophy, calcifications, and ductal obstruction. Ductal obstruction may also affect the common bile duct and can be further assessed and treated with an ERCP or EUS. Other complications of chronic pancreatitis include pancreatic cancer, biliary obstruction, duodenal obstruction, and pancreatic fistulas. Treatment options for chronic pancreatitis include non-operative and operative. Non-operative options include analgesia, cessation of smoking and alcohol, managing exocrine insufficiency with small meals, creon, and multivitamins, and managing endocrine insufficiency with insulin. Operative options can be classified into denervation, decompression, and resection. Denervation is used to provide pain relief and involves the disruption of the celiac ganglion or splenic nerve. Decompression is used to restore pancreatic duct flow and can be done with ERCP and stent insertion. Resection involves removing part of the pancreas to improve pancreatic flow. A number of procedures can be performed. A Frey or Pusteaux procedure involves opening up the pancreatic duct longitudinally and anastomosing the duct to a loop of small bowel and rejoining that loop of small bowel with a jejunojejunectomy. A Berger procedure involves resection of the head of the pancreas and anastomosing the pancreatic body to a loop of bowel, and rejoining the loops of bowels with a jejunojejunectomy. A Whipple's pancreaticojejunostomy involves resecting the head of the pancreas and reconstructing with a hepatojejunostomy, pancreaticojejunostomy, and gastrojejunostomy. Well, I hope that you have learned something new. Please listen to this again to reinforce your learnings, because repetition is key to part of learning new things. And please remember to like, subscribe, share, and comment for more videos.